Welcome to our Ankle Fusion Forum. My name is Nick Cullen and I'm a consultant orthopaedic foot and ankle surgeon at the Royal National Orthopaedic Hospital. If you or your loved one is experiencing pain, stiffness and limited mobility in your ankle due to arthritis, it can be very distressing and have a real impact on your quality of life. Whilst arthritis of the hip and knee is commonplace, many of you are less familiar with arthritis of the ankle. When most people first hear about an ankle fusion or arthrodesis, it sounds very unnatural, and the perception is that this will take away all of the movement in the ankle and foot, making it stiff and leaving them with a pronounced limp. But as you will learn, in reality this is not the case, and most patients will walk quite normally and retain a reasonable movement. An ankle arthrodesis is a well-established surgical procedure which fuses the bones of the ankle together, providing stability and pain relief. The procedure has transformed many people's lives for the better and may be a viable option for you if you've not found relief from other conservative measures. In this video, you'll hear from patients who've undergone ankle arthrodesis and have experienced improved quality of life as a result. You'll also learn from our surgeons, our specialist nurses and therapists who will explain the procedure, the post-operative recovery and the benefits of the operation in simple, easy to understand language. Our goal is to provide you with all the information you need to make an informed decision about your treatment, and we hope that this video will answer your questions and provide you with the knowledge you need to take the next step in your treatment journey.
Hi, my name is Matthew Welk and I'm a consultant orthopaedic foot and ankle surgeon here at Stanmore. I'm here to talk to you about the anatomy of the bones and joints in order to help you make sense of the terminology when we're discussing with you ankle and hindfoot fusions. So first of all, talking about the bones and the names of the bones. There is the tibia bone and the fibula bone, and then there is the talus bone, and the navicular bone sits in front of the talus. And then the heel bone is called the calcaneus, and in front of that is called the cuboid. These are all names that I'm sure you will hear mentioned. And then these all form separate joints around the foot and ankle. You have the ankle joint, which we'll talk about in terms of fusions. You have the subtalar joint, which is the joint between the talus and the calcaneus. There is then the calcaneo-cuboid joint and the talo-navicular joint. Now, the relevance of all of these when discussing with you ankle and hindfoot fusions is which joints are involved when we talk about different fusions. So an ankle fusion itself on its own is a fusion between the tibia, the fibula and the talus, and leaving the rest of the joints around the foot mobile, which is why when you have an ankle fusion by itself, you retain some movement because the joints underneath and in front of the ankle still work. A subtalar fusion is fusing the joint underneath the ankle between the talus and the calcaneus. That will leave the ankle joint still free to move. A triple fusion is fusing all the joints of what we call the hindfoot, which is the talus to the navicular, the talus to the calcaneus, and the calcaneus to the cuboid. And that is called a triple fusion. And the only other one that's left to talk about is the tibio-talo-calcaneal fusion, which sounds like a mouthful, but it is a fusion between the calcaneus, the talus and the tibia. So it's the subtalar joint and the ankle joint to fuse the hindfoot.
Hi, my name is Karan Malhotra and I'm a consultant orthopedic foot and ankle surgeon here at the RNOH. I'm here to talk to you today about how osteoarthritis may affect your ankle. Let's start with what is osteoarthritis. Most simply, osteoarthritis is the medical word for wear and tear of your joints. Now, your joints are wonders of engineering and they have a smooth layer covering them called cartilage. The role of the cartilage is to absorb the shock that goes to your ankle when you walk, and it spreads and distributes the load evenly. Now, this means that your joints can move smoothly and without pain. But sometimes the cartilage in your joint can become damaged, and then it begins to wear away. Now, we don't always know why this happens, but in the ankle, it's often because of a previous injury. Once the process happens, however, it almost always gets worse over time. And as your cartilage wears away, the space between your joints reduces and the bones start to rub together. Now, your bones have a lot of nerves in them, and so this causes you pain. Let's talk a little bit about what symptoms you may have. Now, osteoarthritis can present in many different ways, and not everyone will complain of the same problems. Pain is the most common symptom, and usually this gets worse throughout the day. And that's because as you walk around, the bones rub together more and the pain builds up during the activity. Actually, sometimes patients don't notice the pain as much when they're doing the activity, but they notice that it hurts afterwards, and sometimes even at night. In some severe cases, the pain may be there all the time, and even a slight movement can make it worse. The next thing is swelling, which is also very common. And this is because apart from the cartilage, your joint also produces fluid, which helps to lubricate the joint. And this fluid, you can think of it like a thin oil. And when your bones rub together, your body produces more of this to try and lubricate the joint more and reduce damage. The problem is that this fluid can collect, and sometimes it causes your joints to become swollen. Along with the swelling, the joint can also become hot because at the same time there's increased blood flow, which is trying to heal the joint. Another common complaint that you may have is that you're getting bumps around your ankle that you didn't have before. Or you may find that your foot has changed shape. Now, the reason this happens is because when your bones rub together, your body tries to make more bone to limit the movement. We call them osteophytes, but they may show up to you as a small bump. Also, as bone rubs on bone, part of the bone can start to wear, and if this happens more on one side than the other, then your ankle may start to tilt and your foot will change shape. You may also notice that you get a bit of stiffness and that your foot doesn't move as much as it used to. Once the joint stops functioning well, or extra bone grows around it, you will not be able to move it as much. Also, the pain in your foot will prevent you from moving it, and over time, the tendons and ligaments which support your ankle will also get tight, and this stops you moving as well. Whatever your symptoms, getting the appropriate treatment is key to managing your condition. Your surgeon will take into account all of your individual symptoms and medical history and suggest a treatment plan which is appropriate and specific to you.
I'm Shalane Patel, consultant orthopaedic foot and ankle surgeon working here at the Royal National Orthopaedic Hospital. I wanted to let you know about the various options that you have for your ankle arthritis. There are, in a broad sense, two options. You can either treat your condition without an operation or with an operation. If we look first at the option of no surgery, then there can be simple steps such as altering lifestyle measures. These include weight loss, using more supportive shoes or boots, and using a shoe with a rocker sole where the sole is curved like a half moon. This design means that your shoe does the work of your ankle, and actually many sports companies now incorporate this design into their running shoes, so they've certainly become easier to find. A walking stick can offload a painful leg, whilst an ankle support can reduce movement and help support it better. Physiotherapy is another great way to help, since making your body work in a more efficient manner can reduce stresses through a diseased joint. If we move on to an intervention which is invasive but not surgery, then we're talking about injections, and they can be extremely helpful for both diagnosis and treatment. The most common mixture injected is a combination of local anaesthetic and a steroid. The word steroid can sometimes make people worried, but it's actually a very low dose given in a very select area, so patients don't tend to suffer with systemic side effects that long-term steroid tablets can give. Contrary to popular belief, there is no set limit on how many one joint can receive in a lifetime. But if they work for less than 6 months, we would say that the benefits are not outweighing the risks of that injection.
There are a number of surgical options which are available for ankle arthritis, and what you get will depend on how severe your arthritis is. Sometimes, if your joint is not too bad, but most of the problem is in just one area, such as in the front, then you may be offered a procedure called a debridement. In this procedure, we look inside your ankle, either with keyhole or with open surgery, and we remove any loose bits of bone or cartilage and any extra bits which may be catching and causing you pain and discomfort. This procedure can be very successful in the right patients, but it's important to note that the results may not be long-lasting. If you need more definitive surgery, then you may be offered something called a fusion or something called a replacement. A fusion is when we go inside, remove out all the worn out bits of bone and join the two ends of the bone together. These are often fixed with screws or plates or a combination of these. And once done, the two bones join together and become one so they can no longer rub. It's important to note that this procedure is permanent, and once fused, you never have to worry about that joint again. Depending on how deformed your ankle is, this can either be done through a cut in the front of your ankle or, as I mentioned before, by keyhole surgery. After the operation, you will be in cast for about 3 months, and you won't be able to put any weight through it for the first 1 month. After this operation, your pain should be improved, but you will lose movement in the ankle. However, most people won't miss the movement, and many won't even notice it. And this is because by the time you come to surgery, your movement is often very restricted anyway because of the pain, and being able to walk pain-free is much better than having a small amount of painful movement. Also, there are a lot of joints in the foot and ankle, and the other joints still retain their movement, so your overall movement may still be good, and in fact, many people might not notice that you've had an ankle fusion. However, there are some risks, and one of the risks is that the other joints around the ankle, which need to do a bit more work, may wear out over time. But this usually takes about 10 years and may not always cause you a problem. For a long time now, fusion has been considered the gold standard for ankle arthritis surgery. The other option is ankle replacement. This is where we go in and take out all the worn out bits of bone and replace it with 2 metal plates with a bit of plastic in between. Now, the advantage of this is that it retains your movement, which can help reduce the pressure on the other joints, and it may be preferred by some patients who have managed to retain their movement despite the pain that they have. You can start putting weight on it a little bit earlier, and you can come out of cast much sooner than with a fusion. But at about a year, there is no difference between patients who have had an ankle fusion and an ankle replacement. And the downside is that ankle replacements don't last forever. About 2% of them fail within a year, and to each subsequent year thereafter, which means that about 1 in 5 people who have an ankle replacement will have a replacement which becomes worn out or loose by about 10 years. And if that happens, the ankle replacement might either need to be redone or converted to a fusion. Many things can affect these risks, however, and the specific risk of your ankle wearing out will need to be discussed between you and your surgeon. When making a decision on which treatment we would advise for you, we will take into account all of the problems that you're having, your specific pattern of arthritis, your level of activity, and what you hope to achieve from treatment. Remember, your care will be individualized to you, and please remember that what may be appropriate for someone else may not be suitable for you.
When a decision to have your fusion is made, you'll be offered a date for surgery. You will then be seen or called by the pre-admission team to check you are medically fit for your operation. The pre-admission nurses will refer you on to various members of the multidisciplinary team, such as anaesthetists, pharmacists, physiotherapists, occupational therapy, and diabetic nurse specialists. Their aim is to ensure that you are fit and ready for your operation date. The medical team will also see and phone you in a consent clinic. This is to ensure you are fully informed of the risks and benefits of your operation. This will allow you time to gather information and ask any further questions prior to your surgery. Admission. You will usually be admitted on the morning of surgery at 7 o'clock to our admissions lounge, SAPU. Here you will be busy seeing various members of the multidisciplinary team. Your paperwork will be checked, observations taken, and you will see members of the team. The anaesthetist will assess you and explain your anaesthetic and also discuss pain management post-operatively. The surgical team will examine your foot, mark your skin and confirm your consent form is completed. The clinical nurse specialist will give you their contact details, reinforce the post-operative instructions such as elevation, wound care, plaster care, anti-embolic stockings, blood thinners, and check you have all your post-operative appointments. The physio will teach and check how you non-weight bear using crutches or a frame, and that you are safe on the stairs if needed. If they feel you need further input, they will see you after the operation. You'll be taken to theatre from the admissions ward or transferred to an inpatient ward. You'll usually be in hospital 1 to 2 days.
Once you are discharged, it's important to keep your leg elevated above your groin for 55 minutes in every hour. This will be for the first 2 weeks following your surgery to limit swelling, control pain, and reduce post-operative complications. You can elevate your leg using a few pillows or a rolled duvet. You'll be discharged with pain relief medication. Please take this as instructed by the pharmacist. Post-surgery, you'll be immobile and in cast. Therefore, you are at high risk of developing blood clots. To prevent this happening, you'll be given and advised to wear a stocking on your unoperated leg and blood thinning medications, usually for the first 6 weeks. You'll be in a cast for approximately 12 weeks following your surgery. Usually, the first 2 weeks post-surgery, you'll have a half cast, also known as back slab. This is to allow any space for swelling. An appointment will be organized for you to come back approximately 2 weeks post-surgery for a skin check. The back slab will be removed and your wound inspected. You will receive appropriate guidance on your recovery and support as needed. If the wounds are sufficiently healed, you will go into a full cast. We advise to take great care not to get your cast wet, as this may affect your wound healing. If your plaster does become wet, let us or your local A&E know. You can purchase a plaster waterproof sleeve. It is specially designed to protect the cast while showering. The team will recheck your skin and your progress, usually 6 weeks after surgery. An X-ray or a scan will be taken at 3 months post-surgery. This is to ensure a burn is healing. At this stage, you may be fitted with a walker boot for up to 6 weeks. Remember, it will take up to a year to 18 months to be at your best. If you have any concerns following your surgery, please contact the nurse specialist on the helpline provided. Out of hours, you'll need to contact your GP or go to your nearest A&E.
It usually takes 6 months till you are glad you had your surgery and you are at your best at 12 to 18 months. Prior to coming into hospital, preparation is important. Practice non-weight bearing. Ensure you have adequate support and company around you. Flying and travel. We advise if possible you do not fly for 12 weeks whilst you're in cast. Please discuss this further with your surgeon. Returning to work. This depends on your employment and your ability to sit and elevate. You can request a fit note from the ward staff while you're an inpatient or from the clinical nurse specialist at your follow-up appointment. Driving. If it is your left foot and you drive an automatic, you can drive from 4 weeks after surgery. Otherwise, it is when you are out of cast or your walker boot and safe to do an emergency stop. Please inform your insurance company. Sports. Your foot will be stiffer but pain-free. You can slowly return to activities as pain allows. High-impact activities and sports are not recommended.
My name is Will Rongavilla. I'm one of the foot and ankle clinical nurse specialists. As any other surgery, there are possible complications that you need to be aware of after having a hindfoot fusion. One serious complication is blood clots. It can develop on your leg and may travel to your lungs and will require you to stay longer in the hospital, or if it develops at home, you will require hospitalization. To reduce this, you will start taking medication for 6 weeks after your surgery. It will either be as a tablet or an injection. You will be given stocking to wear on the opposite leg on the day of the operation, and we advise you to continue this for 6 weeks. You can take this off at daytime to have your leg and foot washed, but make sure to apply it again afterwards. We also advise you to keep yourself well hydrated to help reduce blood clots. Post-operative swelling is expected and may continue for up to 1 year. It is advised that you continue to elevate to help reduce this. Any surgical procedure have a risk of infection. We try to reduce this by giving you antibiotic before the operation. Your wound is reviewed at 2-week follow-up appointment. If there are any concerns, your surgeon will decide if there is a need for antibiotic treatment. Occasionally, patients are admitted for further management. There is a possibility that your wound healing is slower than expected. This means that we will need to see you more often until it is fully healed. The risk of delayed wound healing is higher if you are diabetic or a smoker. Therefore, we advise you to stop smoking and get support before the surgery. During the operation, nerves can be irritated. You may experience some numbness and tingling sensation. If you are able, we encourage you to gently massage your toes while you are in plaster. And when you are out of plaster, we encourage you to gently massage your leg using simple moisturizers. Our surgeons aim to set your foot such as it is flat to the ground. Therefore, you can walk evenly and with better balance after the operation. The metal work is not routinely removed. However, if it is causing you pain and discomfort, or if it becomes infected, it may require removal and is usually a day case procedure. Occasionally, your bones may take longer to heal than we would hope or may not heal at all. If this happens, we will discuss with you these options. First, leave it as it is and hope it will unite with regular follow-up review. Second, continue to be in plaster and hope it will reunite with regular follow-up review. And third, start on exogen treatment, which includes a small device that sends low-intensity ultrasound waves to stimulate bone healing and union. Treatment will take for 4 months and may be continued if required. You will be able to do this yourself at home.
Before coming in for your elective surgery, there are a number of things to consider. The first 4 weeks you will not be able to put any weight down through your operated foot. This will make everyday tasks and getting about harder. You may be able to get up and about using walking aids such as crutches. You will need to consider your home environment, and if you live in a property with stairs, it may be advisable to arrange a bed downstairs as they are very difficult to hop up and down. Your therapist can practice techniques with you to ensure your safety on the stairs. Going up and down your bottom is possible, however it can be difficult to lift yourself up from the floor whilst maintaining non-weight bearing. Getting washed whilst in a below-knee plaster cast can be challenging. If you cannot safely use a shower cubicle or bath, you will be advised on strip washing after surgery. It is important to practice getting up and down from your toilet whilst maintaining non-weight bearing prior to your admission. If this proves difficult, it may be possible for you to be provided with equipment that will make this easier. If you are unable to access your toilet whilst non-weight bearing, we may advise on a commode and this may be provided. Before coming in for surgery, it is advised that you have made arrangements for appropriate support with domestic tasks such as cleaning, laundry, meals and shopping. This is especially important if you live alone. Please ensure to make arrangements for getting to and from hospital, and during your admission you will be seen by a therapist who will assess your mobility and can provide further advice on managing when at home. They can refer you to our occupational therapists if there are any concerns about managing personal care after surgery or if there are any further post-operative concerns managing at home.
How long after the operation can I drive? Once the ankle has healed and you're fully weight bearing on your operated leg, you can begin to drive a manual car. This is usually between 12 and 13 weeks. If you've had a left ankle fusion, you can drive an automatic car from about 4 weeks onwards, as long as you can get in and out of the car. When can I return to sport? Well, this will very much depend on what your sports are. It's likely that once your plaster is moved at 12 weeks, it will take a little time for you to build up your strength and your confidence. By 18 weeks, it's likely that you'll be able to build up your walking distance and return to relatively low impact sports, such as golf on the driving range or bowls. Walking longer distances, for example across a golf course, or playing tennis may take 6 months. Running can put extra strain through the foot and the ankle. But some patients do wish to return to run again, and running, they may manage to return to this between 6 and 12 months. However, we tend to advise against running longer distances or higher impact activity. How long does the surgery take? Surgery time is variable, but it usually takes in the region of 2 hours. How long will it take me to recover? Your plaster is removed at 12 weeks. At which stage you will naturally feel a bit anxious and are likely to be a little bit swollen. We say it generally takes 6 months to be good and 12 months to be right. What footwear can I wear post-operatively? When you're in the cast, you will have a surgical rubber shoe that fits over the plaster cast. And once the plaster is removed, we recommend soft lace-up shoes. Training shoes or running shoes are ideal, as they're accommodating and they have a curved sole which helps when you're walking. Will I limp after the surgery? It takes a while after the surgery to build up confidence and to retrain your walking style, which isn't surprising given the fact you've had arthritis for so long, which has caused you to limp, and then we've put you in a plaster for 12 weeks. By 6 to 12 months, most people are walking reasonably normal, so that at a normal pace, you don't obviously limp. If you walk quickly or with long strides, a limp might be a little bit more obvious. Will my pain be gone? Ankle fusion surgery is very effective in treating pain and is successful in 90 to 95% of cases. When can I return to work? Well, this will depend again on what work you do. Many patients will feel able to perform desk-bound work from home from about 4 weeks. For those of you with office work where you have to commute, it's likely to be 12 weeks or beyond that. And for patients who have heavier manual work, return is likely to be 5 or 6 months.